Week 8. I wish it was 8, right? No, not really. Week 6. Week 6 is talking about hematological, immunological, and then there's some cancer like leukemia that you're going to see with this one. Know that next week is your exam. This week is full of reviews. As I said, please try to get to one. You do have a CJ Sims and an NCLEX question. If you did not do your NCLEX questions or your CJ Sims, make sure from last week you had a CJ Sims. Make sure you get it done. It's worth 1.25% of your total grade. And if you are that borderline person, it will make a difference. So please make sure you get your you say it's busy work, but there's some great concepts on those CJ Sims, and of course your NCLEX gets you prepared for your NCLEX, which you want to pass. So we're going to go over our PowerPoint, then we're going to go over a Kahoots. Anybody have any questions about anything? Olivia, can you come on camera? Are you there? Are you available for me, please? There you go. Thank you so much, my dear. Appreciate that. All right, let's go ahead. Let's start with the PowerPoint. Again, if you have any questions, comments, please, you want to share things, share things. Sometimes it's what I share, giving you some examples of some of the children I've seen, and sometimes it's from you if you want to share with me. So, immunological dysfunction. Well, how do we figure it out? Well, number one, it's going to be that assessment. What do you see? Uh, One of the things that we do see, especially with things like any sort of anemia, you don't have enough red blood cells. What do red blood cells carry? It carries oxygen and it carries iron and nutrients to your body. You don't have enough red blood cells. What's your body going to say? I don't have any energy. I have no nutrition. There's no gas in my tank. And you're going to have this comment, this child has absolutely no energy and they used to run around and drive me crazy, right? And then all of a sudden now they're these tired, not wanting to go outside, not wanting to play. That's giving you a hint that this could be some sort of anemia. We know that especially toddlers have a problem with nutrition. They don't want to eat certain foods. And of course, those are your green leafy vegetables and stuff that are full of iron, right? So again, one of the biggest areas of iron deficient anemia are toddlers because of the way they eat and they don't eat enough of the good foods, all right? Another thing that we'll be looking at with some immunological things is infections. Well, what does infections, what would you say? A kid's always sick, right? And then, of course, any sort of bleeding coagulopathies, and we're going to go into them. Could be some bruising, petechiae, nosebleeds, et cetera, et cetera. So, as I said, red blood cells, biggest disorder with any sort of hematological thing. Again, it's because you have less cells to carry less oxygen and less nutrition to the body. So, again, this is going to be a child who's going to be tired. Well, what makes a child anemic? Well, all depends on the age. Now, if you think about the infant, they're born with mom's good hemoglobin hematocrit and they don't start making their own cells till about 4 to 6 months. Now, mommy cells have died off. So they actually go into this sort of anemia because they're not producing yet. Okay. So a normal hemoglobin hematocrit on a 6, 7 month old child could be 9 or 10. And as long as they're not symptomatic, it's okay because now the body is starting to make those cells. Older children, though, we start seeing them, those toddlers and the preschoolers, and their hemoglobin is 10. They shouldn't be. We need to do something in order to build up that blood, get their hemoglobin hematocrit up so they have the energy and their body's getting the nutrition they need. Now, what happens if we let anemia stick there and stay there? Well, the body's pretty cool. It always tries to save itself, right? So if it's not getting oxygen and food, what's the heart going to say? Well, let me beat harder. Let me beat faster. Let me try to get that oxygen. Let me try to get that nutrition around to the body. Well, there still's no oxygen. There's still no iron, so that heart keeps beating and beating and trying, and what happens? They're gonna go into failure because, you only can run so far until you drop, right? Same thing with the heart. They can only beat fast trying to get this stuff around as quick as we can. And this is all, the hemodilution. Well, why do I mention hemodilution? If you suspect anemia in any age person, listen to their heart sounds. You're going to hear that swooshing because there is all of that cells, they're banging off each other and you can hear it. When it's normal, it's pretty full. You just hear blood flowing through the normal ching, ching, ching heart rate. When you see anemia, it's whoosh, whoosh. You hear the swooshing sound, and you really do. It's quite distinctive. So that's the first thing I do is when I suspect it, I'm going to listen to the heart. Of course, I know the heart rate's going to be elevated. And of course, I might see some cyanotic areas. O2 sats might be low. And then, of course, body's not getting the amount of oxygen and iron and nutrition it needs. There will be some sort of growth retardation in the body somehow. They're not going to be where they should be developmentally. Now, there's all types of anemias, whether it's decreased blood cell production, an increased loss, or an increase of blood cell destruction. So we've got three different things, and they all basically will show a lot of the same type of symptoms. So let's go over them. Well, number one is nutrition. When we think of nutrition, we always go to iron deficient anemia. You also could have things like B12. Again, that's nutrition, that's intrinsic factor. But those are usually the two that we talk about. Now, what happens when the bone marrow is not producing enough cells? So, in the decrease in blood cell production, bone marrow is not producing. It could be either some sort of cancer, like acute lymphocytic leukemia, um, any sort of cancer. And then the biggest one we talk about with this is aplastic anemia. Aplastic anemia is all cells are not being produced. We're going to go into that a little bit more in a couple slides. Now, what about increased red blood cell loss? Well, it could be the gunshot wound and you're bleeding out, right? That'd be easy. I know that's an acute loss. But what about things like these little nosebleeds you start to get? One nosebleed, it's not uncommon in children, but what if you're getting more than one a week? More than one a month. Something's going on. The blood, there's a little tiny little surface capillaries in the nose and we start to see bleeding, we need to inspect what's happening there. Of course, blood loss, you think hemophilia, that has to do with one of the factors that promotes clotting is not there. Factor 8, factor 9, von Willebrand's, platelets, something's not there. And ITP is the platelets. Think about the P, idiopathic thrombocytopenia purpura. That's platelets, okay? Decreased platelets, you're going to see those outward signs that they're going to bleed, petechiae and ecchymotic areas. Now, increased red blood cell destruction. We've heard of sickle cell anemia, right? Have you heard of thalassemia? These are where blood cells are born in an irregular shape and they die quickly. Okay? That's why sickle cell children, when they come in a crisis, you can always expect their hemoglobin hematocrit to be low. If it's above 7, I'm happy. I've seen it down to 4 and 5 hemoglobins. So in the ER, giving blood transfusions, that's how serious it can be. And then thalassemia, again, that's all about living on blood transfusions. We're going to go into that a little bit more also. Now, increased blood cell production can be destruction, could be due to some immunological, something's going on. Infections kill blood cells, or it could be chemotherapy. You're going through, some sort of cancer treatment. It does kill red blood cells along with whatever cancer you're trying to kill also. So, how do we diagnose it? Well, again, it's a history and physical. What do you see? What is that child presenting with? And it's as simple with anemia as doing a CBC. We're looking at hemoglobin. We're looking at hematocrit. Those show anemia there. So what are we going to do to treat it? Well, got to find out what's causing the anemia. Is it nutritional or is it one of those other things we were talking about, right? So usually we figure out what's going on. We increase that nutrition or we give iron injections, whatever they need. But in the meantime, your body doesn't have enough volume in it. So we're going to give some IV fluids. Now, they say to put oxygen on, and it's very controversial. Think about it. There's only a certain amount of red blood cells there. Giving oxygen, is it going to increase the oxygen saturation or not? Maybe, maybe not. Not enough cells to carry oxygen. Will it? It doesn't hurt to try. And that's why we usually will put it on. And of course, there's no energy. They're tired. So do not do anything that expends any extra energy. Place them on some bed rest. So as we assess the child, how old is the child? Is it that toddler not eating correctly? Or their racial ethnic background? Are they, African American? Are they sickle cell? Are they from the Mediterranean Sea type area? That's thalassemia. These things can give us some clues. Also, rule out that it's not a GI bleed. Don't just assume it's anemia due to something else. First of all, the most obvious would be a GI bleed that could decrease blood, right? So do a stool for occult blood. And then, of course, in these children, they are going to get some lab works. They are probably going to get some of them. They're going to get medications or transfusions, IV start. Make sure they're prepared, like I've already taught you, down on their level, on their developmental stage so that they understand what's going on, okay? So when you are drawing labs and stuff on children, make sure that they're explained well so they're not going to be distressed. They're already have a weakened, oxygen demand on themselves. They don't have all those cells. So again, making sure they're prepared, having them on mommy's lap, hugging them, those always helps. And that's going to help, creating more problems than you're already working with. So iron deficient anemia, most common of all of the anemias, and it's due to an inadequate supply of dietary iron. Well, think about infants. We either give them breast milk with a little bit of vitamin D, a supplement, or we give them iron formula with iron. And then as we get into 6 months, we're giving them iron fortified formula. So we're giving them extra iron in their diet. So usually, first year of life, usually there's not an anemia that's related to nutrition. It's that normal cells just dying, like I've already explained to you. Times parents think that, okay, we've weaned them off, they're eating, we can put them just on regular whole milk. Well, that's when that milk baby comes around where they're getting calcium and they're getting fat, but there's no iron in milk. So again, that can cause iron deficient anemia. And whole milk, as we've learned earlier, should not be started till 1 year old, right? And at that point, they should be eating a little better, or we can have them eating more iron things, hopefully, to try to prevent the iron deficient anemia. So how do we treat iron deficient anemia? Diet or iron supplementation. Remember, for giving liquid iron, it stains the teeth, like you've learned in pharmacology, should be through a straw, and it should never be with milk before you eat. We want that stomach acid to break down that iron and make it usable for the body. And they say vitamin C, as an orange juice, take with it, enhances the iron breakdown and the usable part of the body. It's a very important concept. And then, of course, if that doesn't work, we can give the IM dextran, which is a deep IM Z-track injection. It burns and it stains the skin. So you need to put it in a Z-track, like you pull the skin back, you put in IM deep, take it out, and then you pull the skin back and it like locks and loads, as I call it. It keeps the medicine inside the body. Now, sickle cell. Many of you have it, know somebody with it, have a trait. It's just one of those common anemias. Now, if both parents have a trait, just a trait, they have each child with a chance of 25% of having the disease, but each parent has to have the trait. Now, what is sickle cell? Very simply, you have these weird shaped cells that are going through the body, and then you get dehydrated for whatever reason. When it becomes dehydrated, those vessels get smaller and thinner, okay? And blood can't go through those cells. They get stuck. So you got this bifurcation, you got the cell trying to get through, it can't, it gets stuck. Well, stuck behind it, and then it gets swollen, gets painful, redden, and it hurts. That's sickle cell. So it's due to those vessels not big enough so those sickle cells can get through. So again, um, that is a sickle cell crisis. Well, why does that happen? Well, you're dehydrated due to whatever reason, or you've had trauma, you've fallen down, you have swelling, ecchymotic area, you have, you know, the vessels are being pressed on. So again, they're smaller, so blood can't get through. It could be infection and fever, right? We lose a lot of fluid when you have a fever. So that could cause those cells to be smaller. And of course, they're out running around playing sports, not rehydrating, dehydration. So this is all of those things that can cause it. So how do you think we're going to treat? Well, it hurts. It's in pain. Everybody's going to say pain medicine's your priority. No, you're treating the symptom. What was the cause? The cause was those small little blood vessels that the cells can't get through. So, what's priority? Bolus fluids, normal saline. Make those vessels be bigger. Put heat on it, dilate those vessels, and that will eventually open up the vessel. Those little sickle cells will get through, decrease that obstruction, decrease the swelling, the pain, and the child is better. Now, I'm not saying putting a bolus on this side and having the pain medicine in the other hand. Absolutely. But the priority is to relieve that obstruction through dilating that blood vessel. Now, many times, sickle cell is due to an infection. They say any autoimmune child, whatever the diagnosis is, if you have a child who's autoimmune, rheumatoid arthritis, sickle cell, cystic fibrosis, on and on, they have a fever of 100.5, they need to call their doctor. That was a Hesse question. Autoimmune with a fever, they don't have any backup. They're already immunosuppressed. They can't fight infection. They will go septic shock very quick. So any child needs to get antibiotics. And sickle cell is one of these things. They're probably going to need some electrolytes. And remember, their blood cells die quickly. And as I said, they're always anemic when they come in, and giving them blood for that anemia. Again, you're giving oxygen, you're giving iron back to that child, and that's what the heart needs. Now, to try to help with the younger children, because remember, young kids don't have a big backup. They don't have any reserves. So they're going to be getting prophylactic antibiotics. I've always seen in my hospital PenVK, one pill once a day, preventative, to try to keep infections away from them. Another thing we're going to do is we're going to be monitoring the reticulocyte count. We're going to evaluate, is that bone marrow working? Is it producing cells? And of course, in order to help the heart give oxygen back to the body, we're going to be giving those blood transfusions for those low hemoglobin hematocrits. I mean, there's no cure for it. We know that it's full supportive. And again, being careful with any infections because they're immunosuppressed. And the biggest reason why young children die with sickle cell is they don't treat that infection quick enough. That's why 100.5 fever, call the doctor or get medical help. They need antibiotics right now. Now, if a child turns to be an adult and are really good and diligent in their care, they can live a long life. So, early intervention, give the penicillin, and then you don't think about this, but there's vessels in the brain. It can cause a stroke. There's vessels in your lungs. It can mimic things like pulmonary embolus, which are very dangerous. And think about the lungs, you're talking about more oxygen being deprived. Those are two big, big problems with sickle cell. Now, children should be treated normally. They need to be able to get up and go out and play sports. But what would you do? Well, you're going to make sure that they're well hydrated the whole thing. If they're in cold weather, keep them warm. Because what does cold do? It vasoconstricts. Blood doesn't go through very easily, right? Also, and I never thought about it, how about up in the airplane where all that pressure goes against those vessels? It can cause sickle cell. So being well hydrated to get on a plane is a big thing also. Now, thalassemia, I call these the rectangular shaped cells. And you can see, yes, they look like rectangulars, but they literally are red blood cells and they burst quickly. They die quickly. Well, what's inside a red blood cell? Oxygen and iron. So think about all that iron being dispersed into the body. You can become iron toxic with thalassemia. One of the big things is hypoxemia and their iron levels being extremely high. These are descendants from the Mediterranean Sea. We have the African Americans, sickle cell, and now we have from the Mediterranean Sea, which is thalassemia. Now, there's four types of thalassemia. Don't have to know all the types. When we usually talk about thalassemia, we think about Woolley's anemia, thalassemia major. This is where your bloods are dying, the blood cells are dying so quickly, you can't keep up with the red blood cells. So these children who become adults are going to need transfusions to survive. There's no other way. They have to come in and get transfusions. Now, usually we don't see it right at birth. Why? Well, they have mommy's blood cells, right? And then all of a sudden they start to change. You see it about 6 weeks of age, and you start seeing those changes coming on. But the thing that alerts the physician to go check in just a CBC is they're looking pale, their growth failure, probably cognitive delay because they're not getting what they need in order to grow, right? So we start seeing those things, we do a CBC, and we do see it. So again, we're going to give blood transfusions to get their hemoglobin hematocrit where it should be. And because it's exploding cells with iron into the blood system, we're going to be monitoring their iron levels. Now, we can give oral medicines like the desferal, and that combines with the iron and it's excreted. Or they might do the iron chelation therapy. It's a machine, it pulls off the iron, similar to like a apheresis or like a dialysis, but it only pulls off iron out of the body. But again, we're getting transfusions, we're getting these medications, we're being hooked up to machines. Can you imagine? This child is always in and out of some outpatient, something to be treated, right? So the care management, well, compliance is a big thing. You don't comply, the child's going to die from iron toxicity or low hemoglobin hematocrit, either or. So the compliance is really required, and it's a lot of work for parents and children. So, nurses become their second friend. They're always with you, right? So again, making sure that you are doing everything to keep that kid, as comfortable as you can. And the parents, they're working with a child who's always sick, always requiring treatment. And then, of course, with all of these blood transfusions, there are blood transfusion reactions. So be aware. What happens if you have a blood transfusion reaction? You think there's one? Number one, turn it off and then worry about everything later and send that bag down to the blood bank so they can monitor it. Blood transfusion, turn it off. Prognosis, they can live into adulthood. But again, it's a lot of work to get there, right? So think about what happens. You're giving blood, your hemoglobin hematocrit gets high. And then the body takes those blood cells and now they die. Now your hemoglobin hematocrit's low. So you're doing good and then you're not. You're doing good, you're not. What is the heart doing? Beating fast, beating slow, beating fast, beating slow. And the heart goes crazy and it goes into heart disease and heart failure. Also, sometimes they'll remove the spleen so they're not producing those rectangular shaped cells, right? One of those things that we do. And that can cause sepsis, which is infection, and multi-organ failure. So they think maybe bone transplantation can help, but it's not been proven yet. So maybe, maybe not. Now, aplastic anemia. Well, when we think about it, it's the pancocytopenia. I mentioned the both type, but in exams and the way we test, it's all about pancocytopenia, and it's the depression of hemoglobin hematocrits, white blood cells, and platelets. Can you imagine? Your hemoglobin hematocrit's low, so you're anemic. You don't have any white blood cells, so now you're apt to get infections. And then thrombocytopenia, P is platelets. You don't have enough, so now you're bleeding. This is one of those diseases where we treat it very similar to leukemia. They give chemotherapy, immunosuppressive therapy, trying to get the body from making these sort of organs, but it is quite an intense long-term care for aplastic anemia. Now, hemostasis, that means you don't stop bleeding. So, hemophilia, biggest one. We think of somebody who bleeds, we think of hemophilia. Comes from mommy. It's an X-linked recessive trait that comes, and mommy is the one who gives it to the child. Now, hemophilia isn't just one thing. It could be a couple things, several things, or one thing that's deficient, whether it's a factor 8, a factor 9, or something that this scientist named von Willebrand found out. These are all things in that bleeding cascade that you need to stop you from bleeding out. This is why your blood clots and eventually stops and a scab is formed and you don't bleed to death. When you're missing one of these, you're going to bleed and bleed and bleed and bleed. Factor 8 is the most common. Now, what would you see with hemophilia? Well, one of the things that you're going to see with hemophilia is bleeding that doesn't stop. You get a cut and they're bleeding like crazy, or they've fallen down and they hit their knee, and now the knee is swollen, getting ecchymotic, and it's starting to hurt. The problem with hitting the knee and bleeding is that joint sac is getting blood in it. So now you're destroying a joint sac. So crippling problems are a big deal with hemophilia, protecting those joints. I mean, yes, ecchymotic areas, that's part of bleeding. We would look at that. Now, initially, in a doctor's office, urgent care, ER, you're suspecting hemophilia. Well, those factors you send to a lab, it's a special lab. It takes a week for those results. So in a quick time frame, what would you see? Well, you're going to look at those bleeding profiles, your APTT and your ET, right? They measure heparin and coumadin, how it's bleeding. Well, that APTT is going to be very long. The normal limit is high as 40. It's going to be 2,000. It's going to be extremely high. Okay, but you're going to see things like platelet count it's going to be normal. So it's nothing to do with platelets. It's a bleeding factor that the problem is. And then eventually you find out what it is. Once we know they have hemophilia and we determine which factor it is, we can give replacements. Now, it's a home infusion. And I'll tell you a story about a home infusion done in the ER by a father and a son. The son was 9 years old. He literally fell down, hit his knee. It was swollen, ecchymotic. They called their hematologist and they didn't answer, so they came into the ER. But the father brought the factor 8 with him and the equipment. Asked our physician, what should we do? And they said, no, there's bleeding. Go ahead and give it. And the father said, do you mind if I do it? And I said, absolutely not. I actually had an orientee with me. So I let the orientee watch this father and the son. And of course, I'm monitoring. I'm telling you, he did it better than most nurses. He washed his hands, laid out his equipment. He had to take this liquid, put it into this powder, make sure it was dissolved, pulled it up into a syringe, put it through a butterfly. The son picked out which vein to use in his forearm, and the son held the butterfly, and the father slowly pushed it in. I've never seen it done that well before, and the son was involved in it, and the father knew what he was doing. So home therapy is a big thing. They get bleeding, especially it's like into the knee. We're really concerned about all those joints. Getting it as soon as possible was the big thing. So that was awesome. Now, sometimes we can give desmopressin, DDAVP. And we can use this for diabetes insipidus too, but that's another week that we'll be talking about that. That's week 7. Anyway, they also have a nasal spray, but these are very mild type of them that we can use them for. So you determine your kid has hemophilia. What is our management? Well, instead of just rice, rest, ice, compress, and elevate when we hit ourselves, what about we protect them from getting cut? Ever have a coffee table, sharp edges, or a table or this sharp edges? It's making sure they're protected so that, especially if this is a toddler you're finding out, so because they're bumping into everything, right? Making sure that the house is safe from sharp edges so they can't cut themselves on whatever. So another thing is their teeth. Again, if we have hard toothbrushes, it's going to cause more bleeding. If we're using dental floss, to be careful so we don't cut into the gums and cause bleeding, because it will bleed even doing those sort of things. And of course, always it's teaching family and teaching that child also. Prognosis is they can live a pretty normal life, but again, it's preventing that joint damage so they don't end up in a wheelchair because they can because of it. Yes, they're working on gene therapy. There's one that's around. It's still not completely done, but again, they're working on some sort of cure for this that they can prevent all of this. Now, ITP, immune thrombocytopenia purpura, ITP platelets. Platelets are low. You don't have platelets, you will bleed. But it's not like cutting and bleeding. You're going to see other signs. That petechia, you see that arm, that little purplish looking thing. I've seen children come into the ER where the mother says this kid never goes out and play. And I was helping them with a bath or something. And I noticed all this bruising and this little purple marks on his legs and arms. I don't understand. He doesn't go out. Well, that makes us think ITP. All right. Usually, what this is they've had some sort of upper respiratory infection, some sort of viral something has gone on, in the recent past. Okay. And what it does, it stops platelets from being formed and they get destroyed really quickly. So you're going to see these outward signs of it. So we treat ITP. Well, number one, you got to determine it is ITP. simple CBC, we're looking at the platelet count. Usually platelet counts are less than 20,000. I've seen them at 6,000. They should be 100,000 or more. Usually they're 3, 400,000, okay? So it's a supportive type thing. Remember this viral infection, upper respiratory? We're going to give IV immunoglobulin, IVIG, boost that immune system, and also anti-D. It's something that's given to boost that immune system for it. Now, as nurses, what do we need to know to take care of this child with when they're in this low platelet time? Well, they're apt to bleed. So if these children bleed easily, we're not gonna just go ahead and put IVs and stick them for blood draws and whatnot. You're gonna avoid venipunctures as much as possible. If there's an IV in, you're gonna use that for blood. You're gonna use that for meds as much as possible because you stick a needle in, they're gonna bleed, all right? You're going to put them on bleeding precautions, watching them for bleeding, soft toothbrushes, right? No razors on that adolescent girl who wants to shave. Sorry, not now, because you will bleed because of, a razor. You don't want those things. And men, nope, you can't use it on their face either. We're going to be monitoring blood counts, which means we're looking at those platelet counts. And with giving the IVIG, anti-D, sometimes we put corticosteroids in there. More yes than no, okay? And we'll be monitoring what do those platelet counts look like this morning. So it's all about bleeding precautions, corticosteroids, IVIG, anti-D. Sometimes the way that we make the diagnosis of these bleeding problems is through frequent nosebleeds. So I said, normal to have one? Sure. But if we're having frequent nosebleeds, there's a problem. It could be leukemia, thrombocytopenia, could be hemophilia of some sort. So something to be aware of if we're seeing a child back in for another nosebleed. How do you treat a nosebleed? And many students have told me this has been a question on your NCLEX. Take your thumb and forefinger, pinch the bridge of the nose, and you lean forward. Now, why do you lean forward? Most of them say put your head back. You put it back, you're going to be drinking the blood and vomit, which will just make the pressure in the nose keep it bleeding. Put it forward. Hold it for 10 minutes. And if it's still bleeding after 10 minutes, they need to seek medical care. Call the doctor, go urgent care, go to ER, go somewhere. They might need cauterized, they might need a whole bunch of things. There's something called nasal tampons they put in there for pressure. There's a bunch of stuff that can be done, but we need to find out why it's bleeding like that. Now, immune things, HIV, AIDS. One of the things that we talk about HIV AIDS is that pregnant mother with HIV. And we know mothers get it, they can give it to their babies. And we also know adolescents, risky behaviors, no condoms, etc. Those are two ways that it can be, given to our pediatric population, right? Well, if a mother is getting prenatal care, they can do something starting at 22 weeks, and it's called HART therapy, highly active antiretroviral therapy, and that can help. Now, why? And then immediately at birth, this infant's going to be placed on these antiviral therapy also. And remember, they're not really born with any immune system, only what mom has, and mommy doesn't have one. So the goal of it is to improve the newborn's immune function. That's the big thing why we give these antiretrovirals during pregnancy and then immediately at when they're born. Some of the big things that we see with children, adults too, pneumocystic pneumonia, big respiratory problem, right? And then, of course, candida. Yeast infections are big problems with HIV and even the children. Again, our big thing is hopefully preventing our adolescents, giving them good counseling. And again, remember, we can give oral and written information to our adolescents. They're asking about birth control. There's no reason why you can't throw in a pamphlet on safe sex, right? So, management of hematologic, immunologic disorders. Well, number one, we're going to be looking at CBCs, white counts. We're going to be looking at platelets. We're going to be looking at hemoglobin hematocrit. We're going to be giving transfusions, and remember, worrying about transfusion reactions as we're giving those things. As I said, apheresis is something that we could pull off iron with or some sort of component. And it also, platelets can be given that way. So you only give platelets in ITP, that idiopathic thrombocytopenia, purpura, that P thing. We can just give platelets to them in order to build that up. Now, many times children are going to have a bone marrow aspiration. I don't know if you've ever seen one or been in a room where they do it. That little blue thing that little thing, that's little line there, they take it and it's a big needle on the end and they put it iliac crest, they can put it in the sternum and it goes, and you can hear this as they're pushing it in. It is quite alarming. Now, they do give something for sedation in children. They do put numbing stuff in there, but it's still going to hurt a little bit. Remember, with children, always be honest. You might have a little pain, but I'm going to do everything I can to make it as little as possible. Again, don't lie to your child. And of course, try to keep them as comfortable as you can because that bone marrow aspiration can give you a lot of answers to the care for this child. So, both parents have 25% trait. What's the chance that each of your children will have sickle cell? Oh, pick a number.
75.
25.
25. 25. Now, listen, you can guess it's okay, whether you're right or wrong. Now you remember it's 25%. Okay, chapter 44, we're talking a little bit about children with cancer. We don't want to think children get cancer, but they do. And I want to tell you, any of you want to get into pediatric cancer? This is one of those things. Once you get certified in chemotherapy and all of those little things with it, this is the one that hospitals will pay you $25,000 sign-on bonuses. Yes, it is a difficult area to work, but it's not all about children dying, okay? Because people die at all ages. What it is what did you do for that child and family when they were alive? And I've got a lot of even parents, children did die that I still keep in contact with, and that's just cardiac. All right, you get really close to these children. So, something to think about for your future. So, neoplastic disorders, leukemia, lymphomas, all of about half of all of the cancers are in the blood, which is leukemia, which is lymphomas. Now, leukemia. This is where the white blood cells aren't working, okay? It is more frequent in boys. And remember, Down syndrome children are at a higher risk. These poor Down's children, not only is it congenital heart defect, it is also leukemia. And the third one is hypothyroidism. So there's a lot of things to look out for these children. Peak onset leukemia is ages 2 to 5. But you know something, today more than ever, with all of the breakthroughs and chemo, children being cured from leukemia. So, what is the name? It's an unrestricted proliferation of immature white blood cells in the blood forming tissue, which means your white blood cells or your immune system is immature and it can't fight. So, in a nutshell, you can understand infection is a big thing that has to do with leukemia. So, my next door neighbor, now it was an older girl. I think she was 12 or 13 at the time, if I'm not mistaken. She went to the emergency room complaining of knee pain, bruising, no energy, just feeling achy and painy everywhere, and had a fever. And they did a CBC, and what they found is she had leukemia. Those are such a the bone pain, lethargy, fever. These are all those symptoms that you will see with them. So they did a CBC, they did a smear, they looked at it and they found, the white blood cells, the lymphocytes just were not what they should be looking for. So they did a lumbar puncture. They want to make sure, is it in that spinal cord? Are you seeing any cells there? And it does affect the care of it. And again, bone marrows again are being done there. Now, with leukemia, they don't mess around with it. Within the first month, they have inserted a port, which is a central line catheter, so they don't have to always get needle sticks for IVs and for chemo, which is pretty cool because it's underneath the skin. So normally they could take showers and do what they want. And when they think that there's a problem, there's a fever, right? They put some numbing cream on it and they send these children to the emergency room to see what's going on. Now, once they determine that's leukemia, we've got the port in, we do 4 phases of therapy. The first one is the most important, and that's called induction therapy. And what they do is, depending on the type of cancer, they might hit them with 2, 3, 4 types of chemo. It all depends, okay, on the physician and what conference they went to. All of these things do make a difference. But what is the goal? 4 to 6 weeks of heavy, heavy hitting chemo. The goal is remission. And you're like, huh, remission? That quick? Yes, but they're little tricky cells and they do hide. So we're going to put it in intrathecal. We're going to make sure that spinal column, brain, everything is clear. And then we're going to do this intensification or consolidation where they give a little bit more, again, for those hidden little cells. And then they're going to put them on maintenance just to ensure that no little cell's going to come back and it's going to attack the body again. So the most important, induction, and the goal is remission. Now, in leukemia, sometimes all this chemo, whatnot, it doesn't work, and we need to do a hematopoietic stem cell transplantation. Now, many of you have had children, babies, and they've asked you if you want to save the cord blood. It's expensive, but what it does, it gives you what we call an autologous stem cell transplant in case you ever had something that you needed it for. Automatically mine, autologous, automatically mine is the best. That's how I remember autologous. And that's actually, if you have, leukemia, if you have that saved, blood, umbilical cord blood, that's the first thing we're going to use. But we know realistically, many people can't save it. So, what's the best thing? And it's what we call all the others, allogenic. So, it's all the others. Some of the best, all the other ones are your brothers and sisters from the same mother and father. That is actually your second one. The thing about this, if it's from another person, it doesn't have to be A positive or O positive. Your blood type doesn't matter. That antigen match or mismatch, it doesn't matter. Um, so what's the best one? Automatically, mine is the best, autologous. Second, allergenic, all the others. And as I said, your brothers and sisters are the best one from the same parents. So you've got a child. Now they have leukemia. They're getting a port in. They're hurting. They're in pain. You're worried about infection, right? They have no white blood cells. They're not making enough blood cells, red blood cells, and you're giving chemo, which is killing a lot of the red blood cells. So hemoglobin, hematocrit are low. Platelets will be low. There'll be all sorts of transfusions given to these children. And of course, that's what we call anemia. And as a nurse, chemotherapeutic agents are very caustic and dangerous. And there are nurses that must be certified to give it. And there's certain precautions that are done. They use certain gloves, masks, shields, all of these things. So, prognosis of leukemia. Well, number one, it depends on what was your white count when you were first seen. Now, the my next door neighbor was zero point 0.1. Well, what's a normal white blood cell? 7 to 10 is a normal number. 0.1. That means 100 white blood cells. Now, if it was 0.01, chances for recovery would have been less. And I've seen it that low, which means 10. How old was this child? Young or old? Was it the ALL lymphocytic or myelolytic? The AML, ALL. Now, what's the difference? Well, ALL is a little easier to cure than AML. AML is a little bit harder of a cell to stop. All right. So ALL is, if you have to have one, would be the best one. And again, your karyotype. What does that mean? Your blood type. Remember, I said you're going to be requiring blood transfusion, platelet transfusions. What if you have a very rare blood type? You don't get the blood when you need it. That can be a problem. And that's what that means. Remember cancer, we do radiation, we do chemo, we do um, all different things for these children. And our goal is just to get rid of all of, if it's encapsulated tumor, to get rid of it, right? And to maintain, the body of quality of life. So again, what are those signs and symptoms? Just like my next door neighbor: pain, fever, ecchymosis, petechiae, and bleeding. Of course, then that lethargy that had been going on for a while, weight loss, just general malaise, of course, anemia, and then firm and enlarged lymph nodes. Those white blood cells are trying, but they just don't work. And sometimes it even goes into their eyes. Now, one of the things, and one of these big concepts, when it talks about chemotherapy, it also talks about other children that are immunosuppressed or very sick. Now, neutrophil counts dictates your immune system. Neutrophil counts are usually over 2,000, which means that's the body's ability to fight infection so you don't go into septic shock and die. Okay. When it comes to children with leukemia, many times, especially giving chemo, they go into this nadir period and their neutrophil counts are less than 500. What does that mean for you as a nurse? This is your sickest child. This child, if they have a fever, this is your priority because there is no immune system. They will go into septic shock really quick and they'll die on you if you don't take care of it quickly. So, neutrophil counts low will always be your priority, especially when it comes to chemo. So, how do we treat it? Well, if you're seeing the blood test this morning, neutrophil counts are 480. That's my priority patient to go visit and see first if I have a group of patients. And it is getting antibiotics in that child as soon as you have them, because it'll help fight the infection, right? And washing hands, wearing a mask, doing all those things you do, for normal universal precautions. Now, hemorrhage is a big thing. Again, platelets are being lost, so you're going to be seeing these children with that petechial and with the hemorrhages, making sure that we price, right? Protect that child from that bumping of things, right? If they are still in the ability, young kids still want to go out and ride their bike, etc., it's not a good idea now at this time, these children should here give them the iPad and let them play video games, because you don't want them out there getting themselves hurt because you can't control bleeding on these children. And the one thing is usually they don't want to because their hemoglobin hematocrits are low. So they will be tired, and again, giving them frequent rest periods, because in eating younger children, giving them time, etc. Um, and rest, rest, rest. Nausea, vomiting is a big thing. It can be very intense. Making sure we give the medicines before they vomit. I'm going to tell you a little story about nursing. I remember first starting nursing, and I had to wait till a patient vomited to give an antiemetic. Is that funny? I mean, today we realize these things are going to cause you to vomit. Let's prevent it by giving the medicine before. So again, changes in practice. And as get in the practice and you become older, you're going to see all of these little changes that make nursing even better than it was. Cannabinoids are used quite a bit. In some children, it's getting more acceptable. The only thing I tell parents is be honest with a physician so they know what you're doing so that you can work hand in hand. The physician knows you're given whatever, so that he can work with you. It's better to tell them than not to say anything. Another thing is altered nutrition. Sometimes their mouths are full of sores. So again, how do we measure nutrition? Well, height and weight measures everything. Daily heights and weights specifically, and then looking at nutrition like protein is a big thing with albumin, making sure they're getting enough healing things, right? Protein and giving them foods that they do want. Now, high protein, high calorie, high fat, which means they can eat smaller amounts because they don't want to eat. Because nutrition is again important at any age for any reason. As I said, mucosal could be mouth to anus, making sure that we address them because if they can't eat nutrition, they're not getting. And then, of course, it can go down to even rectal lesions, and sitz baths are great things. Remember neurological things. Now, as I said, one of the things that happens in cancers is pain. And what do you do for pain? You give pain medicines. What do pain medicines do? They can cause constipation. What does a patient do when they're constipated to have a bowel movement? They bear down. Remember, strokes, big thing with these children. So stool softeners and, trying to give them something more roughage in their diet, but most likely it'll be stool softeners. And again, making sure that they do get enough for pain because that jaw pain, they're not going to eat. I mean, it's a loaded thing either way, but making sure they're comfortable so that they do eat. And then, of course, making sure that they stool without all that extra push. They also can have blood in their urine, so fluids are important and to monitor that. And of course, you always think of chemo, you always think the hair's lost, right? I used to always, with even my cardiac children, I would make little headbands for the little girls, and I would wear one in my hair with them. I would have rolls of yellow and blue and green, whatever color they had at Walmart. those little rolls, and me and the little girl would be making them, or I'd have a boy make one for his mommy. Takes them off of what's going on in there, and it makes me less threatening as a person. I've had parents, I've had brothers, all, uncles shave their heads to be with their kids. And, these things do make a difference. Remember, they give steroids, and sometimes steroids blow you up like, a moon baby, that big face, and, again, making sure that child's comfortable. Sometimes it's just say, hey, mom, get an extra size of jammies for your child, or you picking a different robe so it doesn't feel like it's sticking on them. Older kids think about this, okay? And again, getting them ready for procedure. We do sedate them for many of them. Again, explanations. The biggest thing is using all of our things to decrease the pain, topical anesthetics, and then deeper infiltration. Very important that we do use these sort of things. So, pain management in children, it's opioids. And then remember, just that is positioning, it's heat, it's cold. Use all of them, and it does help. And remember, titrating their doses. They say low dose around the clock is the best thing on these children. Now, health promotion, what do we do? Well, they do need basic care. They still need to be looked at their teeth and immunizations. Remember, live viruses are contraindicated. Okay. Live viruses are contraindicated even with people just on steroids. Remember that. That was one of those big concepts with immunizations. Know that family can get them, okay? But remember, one of the ones is varicella is a live vaccine, but there is one we can give to prevent it because, getting an infection, you have no immune system can be a big deal on these kids. Now, I'm going to explain to you Hodgkin's and non-Hodgkin's lymphoma. And I'm going to tell you there is a question on the exam on Hodgkin's and non-Hodgkin's lymphoma. And I'm going to try to teach you what the differences are so that you know this one. Now, Hodgkin's. Hodgkin's lymphoma is the lymph nodes. It can go to anywhere within the body. Now, Hodgkin's, a Hodge, a lodge, a house, is visible. You can see it. It's large. You can touch it. It's a house. It's a lodge. It's a Hodge. All right? It doesn't hurt. Lymph nodes, usually necks, and it's supraclavicular, means up here. So it'll be in your neck. Now, you can see the pictures of this child. It's a Hodge. It's a lodge. I can see it, right? There's a house coming out of their neck. We'll do a biopsy, and we're going to see what we call Sternberg reed cells. And that's going to tell you this is Hodgkin's. It's the house. I can see it disease, right? And of course, we're going to be seeing things like cough is pressing against the trachea, causing that cough, right? And then fever, anorexia, weight loss, all that cancer things that you do see. How do we treat it? Well, it's this big house. We need to shrink it with radiation, give chemo, and then take it out. These children do well. Big risk for infertility because of radiation and chemo. This is one of those diseases we worry about that. Now, non-Hodgkin's lymphoma, it's not a house. You can't see it. I don't know where it went. It's not a house. Where did you go? Diffuse all over the place. So it's not just up here in the neck, it's everywhere, and it's tiny, and I can't see the house. Where did it go? Non-Hodgkin's, not a house. Again, this is one we try to get a biopsy, and we do almost the same things of them, radiation and a chemo. Now, brain tumors. Brain tumor is a lump in the brain that shouldn't be there that grows. It's either malignant or benign. Now, what would you see? Well, biggest thing you see is a headache that will wake them up from sleep, or vomiting not related to eating. It's just you start to vomit. And then it could go even further on. Younger kids, hydrocephalus, the eyes, nystagmus, um, problems with gait. And then if it's inside, diabetes insipidus, okay? Pituitary gland gets pushed on. And growth failure, another pituitary problem. So this is what you would see. How do we find it out? Well, we're going to see all those symptoms going on. We do a simple x-ray, you could see something. They do a CAT scan, they do an MRI, and we're also going to do a lumbar puncture. Um, this one is that they say the lumbar puncture, because of the swelling in the brain, if we pull out fluid, it could shift it and create more problems. So we don't do it, right? This one we're not gonna. So we're gonna do radiation. We're gonna shrink that brain tumor. We're gonna give chemo, and then we're gonna do surgery. These children, they look like this postoperatively. They shave their heads, their incisions are big, and they're gonna take out that tumor. So postoperatively, number one, how do you position them? Whatever the physician says. Up only 15 degrees. Don't turn it on the side of the tumor. Yes, turn it on the side of the tumor. All of these things are important. One of the big things is monitoring fluid balance. You don't want extra fluid in the brain causing pressure in there, right? And again, keep this kid comfortable. And our goal is to get that kid back to where they were. Now, a neuroblastoma, I'm going to mention it briefly. It's a tumor that starts in the abdomen that fills the abdomen, and you don't realize it until it's already in the brain. So, outcomes are very, very poor on this one. But thank goodness it's not that many children, okay? 6% of them. Bone tumors. This is the one where a child is going to start limping. And it's going to get worse as time goes by. Usually we'll see that limping, we'll give some Motrin, let's see if it helps. Usually it doesn't. We're going to do an x-ray. Simple. Many a times this is the femur bone where it is there. And you have to take the whole bone out. You can't just scrape off the tumor like just taking the tumor out of the brain. You don't have to remove the whole brain, but femur bone, you got to take it all out. So it's called osteosarcoma. Usually, this is that pre-adolescent area where we start to see it. We're going to do probably radiation, do some chemo, and because it's still the tumor's going to be there, we have to take the femur out, which is your upper leg. Well, what they're doing is what we call a salvaging the limb. They take that lower leg and they put it up into the hip bone facing backwards. And why? Well, it's a place for a prosthesis, right? So now they have the ability to walk. Wilms tumor, nephro, it's a kidney tumor. And this is a tumor which you don't want to touch it. I had a case where this 3-year-old boy came in right after the Haitian earthquake many years ago. And people from a religious group dropped him off in the ER. And I said, "So why is he here?" Well, they didn't know. And when I looked at the records, they were all in French. So now I'm like, I'm clueless. So I did an assessment. On the left lower quadrant, I found a tumor the size of a softball. And I was like, that's a Wilms tumor. I have no clue why I knew what it was. It was like all of a sudden I remembered something. What's the biggest thing about it? Well, it is a tumor. And the problem with it, it's fragile. So if you start touching it, manipulating it, little pieces are going to break off and it will metastasize inside the abdomen. Big nursing concept. Don't touch, don't palpate the abdomen. Okay. They don't even do a biopsy on it because that will make a little hole in the tumor and let it metastasize. Okay. Usually postoperatively, because they have to go through the front. Kidneys are in the back. They manipulate the intestines. And of course, you always worry about their kidneys. Post-operatively, monitor their bowel function. A lot of these go into a paralytic ileus because of that manipulation. And of course, monitor for urinary output. Retinoblastoma, kidney of the eye, kidney of the eye, tumor of the eye. And this is, you ever go outside at night and there's animals in the backyard and you see these white, shiny eyes? This is what we call a cat eye or a whitish glow. And it's telling you there's a problem, there's something going on. And the whole eye eventually has to be removed. They do radiation, they do chemo, and then they take the whole eye out. They can't just leave any piece in there. And then they'll put some sort of piece of prosthesis in there. Our goal as nurses, find out, are there any histories in the family or the child, anything that they exhibited with their eyes? I only saw one of these in my career, and it was like a 10-month-old child. Germ cell tumors. This, women do breast exams every month. Well, men should do testicular exams. 18-year-old boy comes into the ER complaining of testicular pain. And I was in the room with another nurse who did the assessment. And what she found was the testicles were the size of almost basketballs. Had gotten so big. And they did an ultrasound and just an x-ray of his chest and abdomen. He had already metastasized all over with a testicular cancer. He died within 3 months. So please, any men, just like women, do your testicular monthly exams, just like women do our breast exams. It is real. I did see it happen. Liver tumors, well, we're lucky we have more than one lobe and it grows back. But again, taking out the tumor. I mean, they say survival rate is 80%. I'm pretty sure it's a little bit better than that today. The thing with cancer is, the treatments have gotten better. Kids do much better, but it's that early treatment. It's that finding it out quick because those signs that we see in all of those social medias, cancer free, I've lived through a few of them with some of my kids, and it is a big deal for that to happen. Any questions so far? A lot of stuff. All right, let's just go ahead. Who wants to win a Cahoots today? I think Amber wants to win in pizza. How about you, William? Maybe? Week 6, halfway through. What is priority treatment for a newborn of an HIV positive mother? Well, what does HIV mean? Talking about immune systems, right? And that's how we answer these questions. I want you to know that just because an infant's born of an HIV positive mother does not mean that child's going to have HIV. I have met triplets. One had AIDS, one had HIV, and one was normal. And that was all at the same time born. So it depends on how we've boosted that immune system. What are symptoms of sickle cell anemia? Remember, sickle cell is when the blood cells get stuck and get clogged, right? That's the whole thing with this. So that swelling, it could be pain, absolutely. Could be in the eyes, and it could be some sort of delayed growth there. What kind of hematocrit would someone with sickle cell have, and why? Well, sickle cells have a short life, right? They tend to die quicker. Or do they decrease production? It's which one of that group is it? They die quicker is the whole thing. Remember I told you if they have a hemoglobin of 7, I would be happy. It's usually 5 or 6 and getting blood. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? So remember, a crisis is when blood's not getting through and there's a backup and there's swelling going on, pain. What's the priority? Your priority is not to treat the symptom. Your priority is to say it's caused by a narrowed blood vessel. Let's plump it up so that the blood cells can go through, and that will eliminate the pain. And as I said, it doesn't mean I'm giving a bolus. I'm going to have the pain medicine in my other hand. But the priority is that IV with IV bolus, plump the vein. What is the reason children with iron deficient anemia are easily tired? Decrease red blood cells, decrease oxygen, decrease iron. Very good. A multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? I've always seen this as a HESI question. I mean, I don't know exactly what they asked, but I do know they talk about iron deficient anemia and supplementation. That's all I know. So, thing about iron is that it's dissolved and made ready for the body by the stomach acid. So, acid helps it. So, on an empty stomach with OJ, if it's liquid through a straw because it will stain the teeth, don't forget to tell that parent that the stool is going to turn black because I've had parents go, "Oh my goodness, the stool is black. What's going on? They're going to die." Never with milk because you're coating that stomach. And again, it's before. Aplastic anemia includes a depression of which blood cells? As I said, I think this is probably the worst, most devastating of all of them. And it is red blood cells, white blood cells, platelets. They're going to be anemic. They're going to be no, can't fight infection, and they're going to be bleeding. All of the above. Most common type of anemia is iron deficient anemia. Very good. What causes pernicious anemia? I didn't mention that name, but I did talk about nutritional problems that causes anemia. And it's B12. So how would we treat it? Well, we're going to give B12 injections. One of the symptoms is a red, beefy looking like tongue, this big red beef looking tongue. And that's what you would see with pernicious anemia. Which symptom is the single most common symptom of anemia? Every kid, every adult's going to complain all the same with this. And that's about fatigue. And then I'll say why. There's no oxygen, there's no nutrition. I can't I have no energy. Very good. Which teaching when teaching parents about beta thalassemia, the nurse informs that their child is at risk for what? Well, those are those rectangular shapes and they burst. What's inside a red blood cell? And what is our biggest concern? We're worried about oxygen going away, so hypoxemia, and then the iron into the blood. And remember, the iron can require medications or even apheresis to get rid of that iron because they can become toxic. What lab values will you see with hemophilia? I mean, yes, we're going to see decreased factors 8, 9, von Willebrand's, but which ones are you going to see in a normal laboratory? And that's the PTT is prolonged. So long APTT or PTT. The prothrombin time is okay, the PT, and the platelets are okay. It's when we see that PTT, like, okay, we can be pretty sure this is hemophilia. What is immune thrombocytopenia purpura? What did I tell you about ITP? Usually following an upper respiratory viral condition. ITP, it's all about platelets. That means there's not enough. What do you see with that? That's your bleeding precautions, right? So thrombocytopenia can cause the following symptoms. If you don't have P platelets, what do you see? And that is those petechial, ecchymotic, and then that nosebleed. Some of the key things is I've seen many ITPs diagnosed with just a nosebleed. Multi. Child with hemophilia has fallen and the knee is swollen and painful. Treatment would include. So, what is our big concern? Hemophilia, you're bleeding. You can see that knee now is getting full of blood. We want to stop that, right? So, we're going to rice it. Rest, ice, contain, elevate. Never heat because that increases circulation. And exercising that knee again will cause more bleeding to occur. What is the nursing priority action for a suspected blood transfusion reaction? What do you do first? You took the vital signs, you come back in 15 minutes as per protocol, and all of a sudden your temperature is 101. What are you going to do? And you're just going to turn it off. Absolutely. Good job. A child is admitted with neutropenia. Which nursing action takes priority? What is neutropenia? What does that mean? Neutropenia is when you don't have enough white blood cells. What do white blood cells do? So, what do you have to be careful with? These are things when you're answering questions you should think about. And the biggest thing is literally strict hand washing. That is the biggest thing that will take a child who has a low immune system, they were not going to get sick. Hand washing. Which symptoms would a healthcare professional expect to see in a child with leukemia? So you have leukemia, your blood, your hemoglobin, hematocrit are going to be low, your platelets are going to be low, your white cells are non existent, bruising, fatigue, bone pain, and you're going to have their fever in there also. So that's exactly it. Your child with ALL has recent lab results with platelet counts of 10,000. Nursing action. So it doesn't matter if you have ALL or a normal child has platelet counts of 10,000. What is your nursing responsibility? What are you going to be careful with or watch out for? It's all about platelets is bleeding. It's bleeding precautions. Good. A multi. A child's placed on bleeding precautions for ITP. What interventions would the nurse do? You get a kid just admitted, went with a nosebleed, found out platelets are on the floor, being admitted to you for treatment. What are you going to be monitoring on that child? So you don't want to pinch that kid anywhere, cause any more bleeding. You're going to watch for bleeding and stool, urine, even the gums. Platelets are going to be monitoring in that CBC. And of course, corticosteroids. Many times, if symptomatic, most of them are. So they do get corticosteroids. Child with a Wilms tumor, a nephrotic, a kidney tumor, which action by the nursing student causes the faculty member to intervene. I mean, something's not right. What did that student do? Leave that belly alone because it will metastasize. That's why we don't even do biopsies preoperatively. A child with ALL has a fever of 100.5. What should they do? We're going to teach children and parents. They have a fever of 100.5. What are they supposed to do? ALL, they don't have white cells. They have no immune system. They need to call the doctor and they need to be placed on antibiotics or be seen by them. Okay. Very important. There's no immune system here. Fever, they're at high risk for septic shock. Child is having a bone marrow aspiration. What should you tell the child? Always be honest with the child. It's going to hurt a little bit, but I'll do everything to help you. Many times they do sedate these children depending on the age of them. Most common clinical manifestation of a retinoblastoma, tumor of the retina in the eyeball. And it's called a cat's eye reflex. It turns white, and that's the way that you would know something's wrong here. Your child has been diagnosed with a retinoblastoma. Information is important. What do you need to know? I mean, part of your assessment. I'm seeing this here. Okay. What are some focus questions, right? And this is all about, is there anything been going on with your eyes that I need to know about? Or is there familiar history about this, which we can direct what's happening here? Or maybe there's another child in the family got to worry about. So signs and symptoms. Very good. A goal of surgery for a child with an osteosarcoma. That is osteo, bone, sarcoma, cancer. And as I said, usually this is your long bone and it's the femur. What is our goal? I mean, it can't always be, but this is what we would really like to see. So we would like to be able not just to amputate that whole leg, but to save that lower leg and put it up and use it for a prosthesis. Salvage the limb. That is our optimal goal for it. Many times it ends up with a complete amputation, but then how are we going to put any sort of prosthesis there to be able to have that child mobile. See, that's our concern here. A child's complaining about skin markings for radiation therapy should be told. You see this a lot with, we have the retinoblastoma, right? And we have these purple things on the eye and they're putting radiation in there. What's the big deal with those things? The thing is, those markings have been very carefully placed to target a tumor. So leave them there because the next time they go for treatment, it'll be in the same place. We used to have, I used to hear some of the nurses, they used to have washing off the marking parties, that they can finally take off that purple and they would have a party with it with a cake or whatever. When distraction is used, it helps what? Children using distraction. Little bit of everything, isn't it? You're not going to think about what's going on. What assessment question needs to be asked to a child with possible rheumatic fever? I'm hitting you with stuff from last week, and I'll always do that. You know that. What causes rheumatic fever?
Strep
Strep
throat.
throat.
Yeah.
Strep throat. And one of the blood tests is called an ASO titer, anti-streptolithin titer, strep in there. It's something that would be drawn to confirm that the rheumatic fever, possible heart problem, right? Valve problem, the only thing we can't turn around to make sure that we're doing what we can, to help that heart not be there, or now to help it because it's already been damaged. Signs and symptoms of asthma. I mean, many of you had it, have children who have it. Who's had it? Sister who's had it. My husband has bad asthma. Coughing, shortening, and remember, signs and symptoms are that expiratory. So air goes down into the lungs, there's swelling, it gets trapped, and they can't get it out. And on the end of a breath, you'll hear just trying to get that air out. Sigh. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? As in, what is something that's dangerous? One of those, oh, I need to tell a doctor right away. I mean, some things you expect, but some things are dangerous. It's all about the headache, worried about a stroke, and chest pain. Is it a myocardial infarction? Is it pulmonary embolus? What's going on there? Now, swelling and sores, it can happen, but the biggest things, or maybe the question should be, asked a little differently, but what's our biggest concern? The headache and the chest pain. Absolute contraindication for nasotracheal suction include which of the following? Anything in the mouth that's already dangerous. When we're talking about croup, it's swelling of the oropharyngeal airway. Epiglottitis, you're already not breathing. And of course, tonsils, you don't because you don't want it to bleed. Iron dextran is given via which route? We use this for iron deficient anemia when they're really severe or they're not taking their oral or any sort of diet that could help increase iron consumption, right? And remember, iron dextran burns. It also stains the skin. So it's deep IM and it's Z-track. Let's lock and load, put it in there and make sure it stays in there. If a child was to receive their own bone marrow, this is called a what transfusion? Automatically mine is the best, so autologous is mine. Allogenic is all the others, right? Good job. What cancer may present with painless, firm, and enlarged cervical nodes? And supraclavicular is all up here. And it's your Hodge, your lodge, your house. It's Hodgkins. Excellent. Good job. A multi. When teaching about sickle cell disease, you would include what? Mm. So you would give a lot of fluid. Excellent. You want to keep those vessels open. Pain medicines, they with like a Tylenol number 3, just enough coating to help them. Again, dressing warmly so they don't vasoconstrict. And of course, medical care, any temperature, because they don't have an immune system to fight. Thalassemia major, Cooley's anemia, is treated primarily with, remember, thalassemia is those rectangular shaped cells that burst. Mediterranean Sea descendants, they say. And it's all about blood transfusion. Nothing else will help. Iron, if you gave them more iron, you're already bursting iron into the blood system. You're on iron chelation therapy to decrease the iron, okay? And of course, they would be on some oxygen because, they have no cells there. Will it work? Maybe, maybe not. Multi. Treatment of an osteosarcoma includes what? So it's either an amputation or it's salvaging the limb, hopefully salvaging. And of course, chemotherapy. Stem cell has nothing to do with this one. That is for like your leukemia, it has nothing to do with osteosarcoma. Multi. Who are the best donors for a bone marrow transplantation? So it is you or your siblings, your brothers or sisters with the same parents. Mom and grandma have half your stuff, so the other ones are better. What is the most common opportunistic infection for children with HIV? And it's pneumocystic pneumonia, PCP pneumonia, most common of all of them. Second might be some candida yeast type thing, which causes, of course, sepsis. What would you consider to be neutropenia or a low neutrophil count in children? And again, any child, whether ALL or whatever, you've got a low neutrophil count, that is a child who's at high risk to going into overwhelming sepsis. That is your priority patient always. Neutropenia is less than 500. It should be somewhere over, 1,000, 2,000, depending. A primary characteristic of a brain tumor. This little lump in the brain is occupying space and growing. What would you see? Mm. So your symptoms get worse over time because it's growing. Headaches that wake you up at night, and vomiting not related to eating. Of course, you might see, your balance going off as it grows too, depending on where it's located in the brain. The optimum treatment for an osteosarcoma is your optimum treatment is salvaging the limb. You cannot leave that bone in there. So you can remove the tumor off the bone, but still there's cancer there. You have to take all of that bone out of there. So the whole upper leg is gone. So all you're left is the lower leg, and hopefully we can use that, reattach it so we can use it for a prosthesis to be able to held there. And last question. A child is receiving the induction of chemotherapy. What does induction mean? Remember, there's 4 levels. We know that induction is the first 4 to 6 weeks of chemotherapy. And our goal is remission. Now, why are there other 3 steps there? Because there are cells that will hide. And we have to make sure that all of them are gone. Okay. Very good, guys. Tia. Good job, Tia. Number 2, the Black Plague. Okay. Number 1, Stella. Good job, Stella. Shelly and Justin. Good job, guys. So remember, this is the week of all of the reviews. I will be posting mine tomorrow after I give it. I believe there is a 9 a.m. on Wednesday and mine at 2 p.m. All of them are listed in your announcements with also the new up-to-date study guide for you. Again, anybody who needs me, please just let me know and I will help you through it, okay? Any questions? Thanks, guys. Have a good night.